We are live.
Good evening, everyone.
Good evening.
Thanks for joining us this evening. I'm Dr. Tinku Bali, your moderator for this episode. And on behalf of AIOS, I warmly welcome you to the third episode of GuruSangam 24-25 edition. Well, the idea of GuruSangam took off last year and was extremely well received by not only the postgraduates, but also ophthalmologists at various stages of their career. So through GuruSangam, we give you an in-depth coverage of various topics by a stellar panel of academicians. And this GuruSangam program promises to turn confusion into clarity and give you a detailed coverage of the topic, not only the theoretical aspects, but also the practical aspects of the topics covered. So with that, I welcome once again our panelists, our speakers, and the audience that is with us this evening. So I thank the president of AIOS, Dr. Samar Basak, for supporting this idea, and Dr. Santosh Honawar, whose inputs have carried this program forward. Today we have an expert panel with us who will be giving their inputs at the end of the talks. So we have Dr. Alka Gupta, who's a professor at the LLRM Medical College, Meerut, and a very keen academician. We have Dr. Gopal Pillai, who's the head of department at the Amrita Hospital, Kochi, and also the chief of the Vitreoretina services. He's also a very, very keen researcher. Apart from that, we have Dr. Rakesh Purwal, a renowned ophthalmologist, and who's also the director of the Rakesh Purwal Clinic at Ajmer. So very warm welcome to our expert panel and looking forward to your inputs after the talks. With that, I move on to introducing our first speaker, that is Dr. Pooja Hingorani Bang, who is the founder, head of Department of Ophthalmology at AIIMS Nagpur. So just to give you an overview of her career path, she did her MBBS from the GS Medical College and KEM Hospital, Mumbai, and her PG from the TN Medical College and Nair Hospitals, Mumbai in 2006. She additionally cleared the DNB, FCPS, DOMS exams with a bronze medal. She also had a stint at the MGIMS Sevagram for over 13 years, where she served as an assistant and then an associate professor. She is currently the founder, head of the Department of Ophthalmology at AIIMS Nagpur, and has been there since its inception in 2019. She has a vast experience of over 18 years of undergraduate and postgraduate teaching. She has curated the MBBS and MS Ophthalmology curriculum at AIIMS Nagpur. She also initiated the MS Ophthalmology program at the same institution. And she also is a policy maker at the National Program for Childhood Myopia. So with this illustrious career and a vast experience in academics, I think she's just the right person to give the PGs tips on how to ace the case. So she will be today talking to us about how to face the exam and make a step-by-step diagnosis writing in ophthalmology exam cases. So I'm sure this is going to be a very, very useful talk for the postgraduates. And looking forward to your talk, Dr. Pooja. Over to you.
Thank you, Dr. Tinku, and I thank AIOS for this wonderful opportunity. And if I may, then I'll just share my slides then.
Yeah, sure. So while Dr. Pooja is sharing a slide, I request the audience that is with us to please keep your questions coming. Let us make this as interactive as possible. So you can post your questions, queries, any clarifications you want in the chat box, and we'll be taking them up at the end of the talk. So looking forward to the talk. I'll stop sharing.
Are you able to see my screen?
Yes, clearly.
Okay, so welcome everyone, and we are going to see how we can write a diagnosis by going in a very methodical, stepwise manner. So of course, I have no declarations to make, but the declaration, yes, that I'll try to kindle the interest, no conflict of interest, yes. So we shall cover the definition of a diagnosis, the common mistakes that we encounter as teachers when we hear a case presentation by PGs, also the basic principles of writing a diagnosis, of making a diagnosis in the first place, the components and the types of the diagnosis, as well as some practical applications, including examples and tips towards the end. So what is a diagnosis? So Greek means dia means apart and gnosis means to know. So to discern or distinguish one from the other, to know one thing apart from the other. So that is a diagnosis. So it is simply the act of saying exactly what illness a person has and what is the cause of his problem, or in more medical terms, it is to identify the exact disease condition or injury from a set of symptoms. So we have many teachers here, and sometimes we wonder under what domain does a diagnosis writing come. So definitely it comes under the cognitive domain. Yes, in fact, under the Bloom's taxonomy, it comes very higher order in the cognitive domain. So not only does the student have to analyze the data that he has collected through the history and the examination, but then he has to create or formulate the diagnosis, synthesize the diagnosis. So yes, it is also a skill, as we shall be learning in today's session. It's almost, I'll try to make it almost like a workshop. And yes, communication definitely, because you have to communicate the diagnosis not just to the patient, but also to the examiner during your exams. So at the end of this session, I hope that the students will be able to navigate through the technique of actually synthesizing the diagnosis, understanding its parts and types, and using maybe a template to write a diagnosis so as to get a complete comprehensive ophthalmic diagnosis at the end of the case presentation. So why do we need a template? Because now over the years of teaching and not only making presentations, but hearing presentations and lots of exams witnessed, examiners interacted with, there are some errors, there are some common errors that PGs make. And so there's a simplified technique which can help them to avoid these errors and to kind of formulate a diagnosis through a template. And of course, if you wish, you can use the similar template in a modified manner elsewhere as well. So what are these mistakes that the PGs tend to make? It's very common, say, okay, tell us your diagnosis. So say, ma'am, cataract. Oh, that's just incomplete. And it's a very casual way of saying cataract. Well, they will not even sometimes mention the eye. Ma'am, it's a right eye cataract and a right eye mature cataract and left eye mature cataract. They forget the systemic components. This is very relevant because they've been through the post-graduation for 3 years and 2 or 3 years, and still at the end of the case, one needs to know whether we'll be able to proceed, for example, with surgery. So if it's a cataract and you cannot proceed with surgery because it's an uncontrolled diabetic, then it's very necessary to know that the patient is fit in every other way, what other systemic confounding factors can be there. And then, of course, they forget secondary features, they forget relevant points from the history, and they do not mention the severity of the type, the diagnosis. And of course, they mix up between what should be spoken in the examination, the findings, and the inference, which is the diagnosis. And finally, later in life also, I tend to see that during the clinics and when PGs are actually seeing patients, they tend to treat the symptoms more than without even knowing what exactly the patient has. Sometimes they, without even knowing the diagnosis, they've started the treatment. And this is something that we need to be really careful about. It kind of reminds me of my favorite hobby, which was at the time of PG, it was to read mystery novels. And I used to read a lot of murder mysteries. So let me today try and equate this process and try to make it more interesting by equating it with a murder mystery. So the investigator now becomes you, the postgraduate student, the doctor, and the solving of the mystery. Who has done it? What? Who is the person? Who is the killer? Or who is the person who has killed? Or who's the murderer? Yes. So that solving the mystery is actually making the diagnosis. And let's say the event has occurred, the attack has occurred. So what is this attack? What is this event? If you compare it to what is happening in the body, yes, it is the disease. The disease has occurred. Here in this case, I have shown it as a cataract. So the disease has occurred. Who is the victim? Well, the lens. The lens is the victim. The lens has, got the cataract, has undergone the event. So, and who is the witness? The prime witness who will be able to tell you everything about it, And yes, that's the patient. That's the patient. He'll be able to tell you everything you want to need to know about it. And the witness statements are the most important because that's where you go from. That's what helps you, leads you to the killer or to the murderer. And which are the witness statements that we see? Yes, so the primary witness or the patient is someone who gives us the history, and that is the witness statement in this case. So it's very important. It's evidence for us. It's starting of the evidence for us. And then, of course, after collecting the prime witnesses' statements, the investigator goes ahead and looks for clues, all types of them. And what do we do as doctors? We actually do the examination. We are looking for clues. In this case, it's the iris shadow. In this case, it's the type of cataract, the color of cataract, extent of cataract, the grade of cataract. Yes. So we are looking for clues. And how do we sift out these evidences? So whatever we have found in the history and in the diagnosis, whatever is significant, I encourage you to underline it or to highlight it or to mark it. Why? Because it's all these symptoms and signs, the symptoms from the history and the signs from your examination, which will help you formulate your diagnosis. And how it will be done, we are going to come to it later. So finally, it often happens that the investigator, Sherlock Holmes, Poirot, whoever is your favorite, they will not have the final murderer or the final culprit in front of them immediately. They have 2 or 3 in their mind. It could be this person or this or this. So this is what they have, the prime suspects. And for us, that is equivalent to the differential diagnosis. Sometimes we do not know exactly. It could be this, it could be this, or it could be this. Yes, so that is equivalent to the differential diagnosis. And the actual criminal, when he zeroes down on the criminal from amongst the prime suspects, well, that is clinching the diagnosis. So yes, so be ready now to wear your investigator's hat and to solve a mystery. I hope it's more interesting for you if you look at it like this and without actually finding the criminal. How will you punish the criminal, right? So how will you give justice or how will you execute it? So justice for the crime and executing the criminal, these are the 2 components of the treatment. So for us, in this case, it was cataract. So justice for the crime, yes, you replace the cataractous lens with a clear IOL. And execute the criminal, yes, you remove you phacoemulsify or you remove the cause or the cataract. So what is exactly making the diagnosis helping us to do, or where is it placed in the middle of all this? So just as we just mentioned, it is placed between the history and examination on one side and the management on the other. So the prerequisites are the history and examination, some investigation, some references that we have, but it is also a prerequisite and assist in the management, because it's very confusing and if one doesn't know where to go after this. So unless we have a diagnosis, unless we have a sign on that signboard, we do not know which road to take, which treatment to give, how much to give, which road is faster, which treatment is better. So yes, it helps in the management, further evaluation of the patient, sometimes further investigations. It leads us to the correct references, and that is what it helps us finally do. So the history examination leads us to the diagnosis, as in this case. And in the second picture, it shows that it helps us choose between the paths of the treatment. So what are the parts of a diagnosis? I would always say, because we are an ophthalmologist, we will start with the ocular diagnosis first. So ocular diagnosis followed by systemic diagnosis. So ocular followed by systemic, but yes, right eye followed by left eye in ocular. That is a convention. Please do not say, ma'am, left eye, cataract. Okay, what about right eye? Ma'am, right eye is normal. Even if it's normal, say right eye normal and then say left eye cataract. It is a convention. Please say right eye before left eye, and then you can maybe go ahead with the systemic diagnosis. At this point, I would like to say that some colleges, and it's appreciable if you can do that, you may do that. They give a small kind of a summary of all the positive or significant findings. My patient, a 55-year-old, came with this and showed up with this and has a diagnosis of, and then they say the diagnosis. That is optional, but the actual diagnosis needs to be written like this. And yes, in each eye, now that I'm going to the right eye diagnosis, now I'm interested, what is the diagnosis of the right eye? So, I'm sorry. So first of all, we need to, as I said, get the significant points of the history and examination. By significant, I do not mean abnormal. They should be the odd ones out. So for example, here, the red is the odd one out among the yellow. And here the yellow is the odd one out amongst the red. So whatever is the odd man out in the symptoms and signs, underline it, highlight it, do something so that you know that these are the points with which you have to combine these and make it into a diagnosis. So how will you do that? Now, a case in point, I'll give you an example. Here, the abnormal or the odd man out is this rotten apple. Okay. And just imagine we equate it to a blood pressure or high blood pressure, an abnormal blood pressure, just like this is an abnormal apple of 200 by 100. But in this case, what is the odd man out? Here, the good apple is the odd man out. So the rotten apples and the good apple is the odd man out. So imagine, when can a blood pressure of 120 by 80 be still significant? It can be significant when a patient is a known hypertensive. So it is significant if he is on treatment. Is he controlled or is he not controlled? So yes, even a normal finding, when it's expected to be abnormal and it's still normal, is significant. So all significant findings need to be underlined. Visual acuity is always significant. Please note that. Visual acuity is always significant, even if it's 6/6. So ocular diagnosis, what are the parts of an ocular diagnosis? So look at this picture. The patient thinks, now suppose here the main problem is shifting the sofa from one place to the other. The main problem is the sofa. So that is our primary diagnosis. The patient also believes that he has come for this. This is what the patient has come for. And that is usually the one which is more important as well. So that becomes the primary diagnosis. By the way, someone else is being shifted with the sofa. That becomes a secondary diagnosis. It's something that it's an accessory diagnosis or something that we catch as we go along the examination, and it may not be the reason for which the patient has come. But sometimes the patient comes for one reason and we may find something even more important. For example, a patient comes thinking that he has a refractive error, but he may be having keratoconus. So we need to treat the keratoconus. In that case, it's not necessary always that the primary diagnosis has to be the one which is more important. So we come to each eye having a primary and accessory diagnosis. So the same slide, and now every eye will have one primary and one accessory diagnosis. If there's an accessory diagnosis, there need not be every time. So now, what are the parts of a primary diagnosis? This is what I find that if you know this template, you'll never miss any part of the diagnosis. You'll never miss any, the structure of the diagnosis will be complete and very comprehensive. So these are the parts: the anatomical, pathological diagnosis, the etiological diagnosis, the clinical diagnosis, and the complications and prognosis. So what does this mean exactly? Just looks like 6 words, right? So let me explain again with our same example, the example of the investigator and the murder mystery. So here we have a whole set of symptoms or signs, significant points which we have already underlined, right? We've already underlined and highlighted these points. Now, if we ask the question, which person has killed this victim? So what all among these clues, or amongst these evidences, what all evidence will be used for that, for identifying the killer? Yes, fingerprints, footprints, maybe even lip prints on glasses, etc. Yeah. What about if we have to ask the question, how did this happen? How did this wound happen? How did this murder happen? So then we'll have to find the pathology behind it, right? The whether it happened with a gun or a blade, or a bomb or a knife. What about etiology? Why did it happen? Why did this murder happen? So was it due to anger or was it due to self-protection, right? And the last in this slide is the clinical part. So clinical simply means you're finding a pattern to it. Is it a serial killer? Does he always kill in this way? Was there a pattern? Was there a circumstance? Was there a situation at that time? So anything situational, anything which gives a pattern, anything that classifies it is a clinical diagnosis. So here, let me give you a tip. The simplest tip to give here is, for example, ptosis. When we learn ptosis, we learn so many types of classification for ptosis, right? We learn mild, moderate, severe. We learn with good levator action, without a good levator action. We learn the mechanism of ptosis. We learn the etiology of ptosis. So all these are classifications. So the tip here is pick up one from each classification. So it may be a mild ptosis with good levator function, which is neurological and due to which syndrome then? Due to sympathetic Horner syndrome, right? So this is something like, this is the complete diagnosis. In this case, only the clinical diagnosis for the ptosis. So the clinical diagnosis will be, it's a primary, mild. So from each classification, you pick out the correct word in this case or in this particular patient. And lastly, what about the complication? So in this case of a murder mystery, what can be a complication? Well, the body is very old, or it has to be exhumed, or it has been run over by a truck, or it has been in the marsh for a long time and all the signs are lost, all the evidence is lost. So similarly, there can be complications of the disease also. And prognosis. So will the murderer be hung, or will he serve a life sentence? And of course, there are secondary parts of the diagnosis. What is the secondary diagnosis in this case? Like in a murder mystery, it could be like the person has been killed, yeah, but someone has robbed the dead body, someone else, or someone has cheated him of his will, or someone has stolen his mobile, used his thumbprints, and made a cyber crime out of it. So it may not be related to the actual diagnosis. It may not be related to the actual murderer. So these are the accessory diagnoses. These are the secondary diagnoses. So let us now come to the actual case. So let us solve this case. Let us make a diagnosis right now, here and now. So here there's a patient with diminution of vision in both eyes, gradual, painless, progressive, 72-year-old, known hypertensive, but BP is fine. Vision is 636, white pupillary reflex, iris shadow. So let's go anatomical diagnosis. What will be the anatomical diagnosis? So it will be both eyes. So which part of the eye is involved? Which part of the eye is involved? So seeing that there's a white pupillary reflex and the iris shadow, it's obvious that the lens is involved. So right now we've got both eyes and lens in our anatomical diagnosis. What about pathological diagnosis? What has happened to the lens? What is wrong with the lens? So in the pathological diagnosis, something is wrong with the lens which has caused diminution of vision, which is almost 6/36 and it's grayish white. Something has become grayish white and there's an iris shadow. So there's an opacification of the lens. Of course, lens and opacification together makes it cataract. So right now, when we say both eyes cataract, it simply means that you have the anatomical diagnosis and the pathological diagnosis. You do not have the others yet. So when someone says, ma'am, diagnosis is cataract, they actually have a very small part of the diagnosis. So what is the whole diagnosis in this case? In this case, the etiological classification would be senile cataract. So both eyes, senile cataract. What about the clinical diagnosis? So here, the staging, the grading, the classification, whatever you know. So here, it is the grayish white pupillary reflex and it is an immature cataract. So these three symptoms, these three signs, visual acuity is not so bad that it's a mature cataract. It's grayish white, it's not white. And there is an iris shadow, there's no absence of iris shadow. So this classifies it as immature, not as mature, not as hypermature. So yes, so that makes it immature cataract. So these are the, so right now, if there's no complication in this case, if there was no prognostic problem, then this would be a bilateral senile immature cataract. Okay. And of course, you can have a cortical component, you can have a nuclear component. So you can say it can be a both eyes, cortical, a senile cortical immature cataract. That is your diagnosis in this case. But okay, let's for the sake of it think that there has been a complication. So if it was a painful diminution of vision with recent redness and photophobia, vision has reduced still further, it has become a white pupillary reflex, then the IOP has increased, there's blepharospasm, so obviously there's some form of a glaucoma which has developed due to this lens, and hence the complication in this case, we would add, okay, this is a cataract, such and such cataract with mature cataract with lens-induced glaucoma. What about the prognosis? What do you mean by prognosis? Why should you write it in the diagnosis? I always say that now, for example, there is a glaucoma and it's an angle closure glaucoma. But the angle closure glaucoma with a good visual prognosis, which is treated immediately, which will come back to 6/9 tomorrow, versus an angle closure glaucoma, which is in its absolute stage. It will not come back. There'll be a projection of rays, a loss of PL and PR. So how, by just calling it glaucoma, you will not understand the prognosis until you say something about the prognosis in the diagnosis also. So for example, absolute glaucoma. So that makes it a bad prognosis, right? So if in this case, the projection was inaccurate and the IOP was not just high, but very high, then in this case, we would have called it lens-induced glaucoma, but end stage, right? So this is how we go for the okay, now it's not necessary that every patient has to have this fourth and fifth component, which is the complication and the prognosis component. It may just end at clinical. So anatomical, pathological, etiological, and clinical diagnosis need not have any complications or prognostic issues. So let's go back to our original symptoms. So here, what would the secondary diagnosis be? Not related to the primary diagnosis. So here you are, arcus senilis, maybe senile anophthalmos, and a pseudotosis due to that. So these are not related to our primary diagnosis, which was cataract. But yes, they need to be written here because you found them, you found these symptoms. And of course, the rule is, and I'm going to stress this rule later, that all signs and symptoms which are significant need to find their way into the diagnosis. All of them need to find their way into the diagnosis. None of them should remain by themselves or without finding their way into the diagnosis. So what if we add this one more component to it? The vision improves to some extent. So in that case, we will also add the component of refractive error to it. So what about systemic? This is the last part of our diagnosis. So after right eye, left eye, primary, accessory, we have the systemic diagnosis. So here, a known case of hypertension, controlled on treatment. Here, the BP is controlled, and in a known case of tobacco addict. So this would be the entire diagnosis, which seems something like that. Both eyes, immature senile cataract with refractive error, with arcus senilis, in a known hypertensive controlled, in a tobacco addict. So this would be the entire diagnosis. Now, what did we do? What did we just do? We made a clinical diagnosis. Why? Because we based it on our history and on our examination. So we made a clinical diagnosis. Now, these were the components of the clinical diagnosis. What is the difference between a provisional and a final diagnosis? Sometimes the clinical diagnosis may be provisional, sometimes it could be even final diagnosis. But the difference is that if we still have an element of doubt, or if we still have to confirm the diagnosis with an additional investigation, in that case, it becomes a provisional diagnosis. And a final diagnosis, when it is proven without doubt, when it is established what the diagnosis is, then it's a final diagnosis. What then is a differential diagnosis? So differential diagnosis, as I earlier said, is a set of 2 or 3 diagnoses when you do not know exactly which one it could be. You may need an investigation or further tests to prove or disprove one from the other. Usually, at the end of a history, we can have a differential diagnosis. Usually at the end of the examination, we generally have one working clinical diagnosis on which we can work and treat the patient. Of course, there's something which is slightly unrelated, and that's the spot diagnosis, and that's for your OSCEs. There can be OSCEs in your exam, and you may have to give a spot diagnosis. That is, of course, different from the rest of these. So, as I had said earlier, every point that you have marked, every significant finding will find its way into the diagnosis. Sometimes 3 of them might lead to just one word, like we saw in the case of immature. The vision, the grayish-white reflex, and the iris shadow all led to the word immature. Many may lead to one, or one may lead to many. As we saw that cataract, when we said cataract and when we said immature cataract, for both we use the vision. So one may lead to one symptom, may help us to point out or flesh out the diagnosis in many components, whereas many symptoms or many findings may help us to flesh out a single component. So finally, we come to the differential diagnosis, and from there to the final diagnosis. This is how we go. Now let's just give 2 more examples just to make sure that you've understood this point. Let's say what could be the anatomical diagnosis in this case. Here, it's a right eye, and this is scotoma. So it has to be something related to the retina, right? So right eye and scotoma, either retina or optic nerve, right? So okay, so this is the anatomical part. It's the organ involved, or the part involved is the retina, the right eye retina. Okay, what about the pathological diagnosis? See these red points. It's a painless blurring of vision. It's a 43-year-old male. There's work stress. There's a vision improvement with plus 0.75 diopters. There's a central relative scotoma. There's a circular reflex at macula. So yes, the pathology is a central serous chorioretinopathy. But this is not yet the complete diagnosis if you follow the template that we have just seen. So what could be the etiology? Look at the green pointer. Yes, it is lifestyle induced. So what about the clinical component of the diagnosis? The clinical component, look at the blue color. So it is the second episode. So here, the classification is not primary, it is recurrent. So all acute, subacute, chronic, primary, recurrent, progressive, or stationary. All these classifications you can put under clinical, because they will tell you about the status, the pattern, and the presentation. So that is a clinical form of the diagnosis. What are the complications and the prognosis? Is there any complication? Or yes, there is reduced contrast and a scotoma. So that is a complication. So what about the accessory diagnosis? Yes, he has presbyopia because he's 43. That is expected. And yes, he is not yet a known hypertensive. So we will say it's a newly diagnosed hypertensive and not on any treatment. What about, this is another example. So this is example number 2. Let's solve it together. So now again, this is right eye. Okay, right eye. And it's involving the conjunctiva or the surface. So there's a fleshy mass on the surface. So what is that fleshy mass about? So see the red colors, the fleshy mass in the right eye. Okay, so it's a pterygium. What about the etiology? So this person is a laborer. So it has to be ultraviolet light induced due to limbal stem cell deficiency, which is known now as a cause of pterygium. What type of is this? So it's just a recent onset. He's just started. So it's a primary pterygium, but it's on the medial side. So and it is progressive, because just look at the corrective. There's an astigmatism. It's progressive. It's stage 2 because it says 3 millimeters. It's vascular and it's medial. So, and the complication is it's caused with the rule astigmatism. So clinical diagnosis is it's primary, it's progressive, it's stage 2, grade 2, because it's 3 millimeters, it's lying between the limbus and the pupil. And the complicated part is that it is a with the rule astigmatism. Yes, and the patient has presbyopia. The patient is an recently diagnosed diabetic, and he seems to be having a suspected diagnosis of COPD. He's a BD chewer, BD smoker. So finally, why are we doing all this? Why are we learning how to write a proper diagnosis, a complete diagnosis, a comprehensive diagnosis? Because yes, in your practicals, usually in most universities, there are 5 practical cases which you have to take. 1 long case, 2 anterior, 2 posterior, usually. It can be more than this also. In the OSCEs, you can have a spot diagnosis. Even in the theory paper, as MCQs, both type A and type B. Type A MCQs can just tell you what is the diagnosis if A, B, C, D happens. Or type B is indirect. They'll say, if the patient has this symptom and this sign, what will be the treatment? So they won't even ask you for the diagnosis. They presume you know the diagnosis. And then again, everyday practice, not just PG life, but every day to come. Every patient, you need to make a diagnosis. So what are the pointers at the end of it? Use this presentation just as a checklist. Don't go and say clinical diagnosis, anatomical diagnosis, pathological diagnosis, or complicative diagnosis, or etiological diagnosis. No, just smoothen it out into a good sentence. But make this just as a checklist. Have I got my anatomical diagnosis? Have I got my pathological? Have I got my etiological? Have I got my clinical? Are there any complications? Is there any prognostic problem? What is the accessory diagnosis? What is the systemic diagnosis? It should be complete and composite. You may suggest a differential when 2 or more seem likely. No often findings. So do not leave any findings either in the history or examination which have not found their way into the diagnosis. Use words like suspected or to be ruled out or likely or suggestive of when you're not sure and you need a corroborative investigation. A working diagnosis may be necessary when the etiology is not clear. Use all classifications possible for the clinical categorization. And finally, the pathological and the clinical diagnosis are the ones which help you first to formulate and then to fine-tune the treatment. Because how severe is, suppose it's an acute onset, your treatment may be different. If it's chronic, your treatment may be different. So the clinical part of the diagnosis and the pathological part, these are the ones which will actually help you to a greater extent to fine-tune your treatment. Finally, the diagnosis that has to be conveyed to the patient. And this, of course, is not part of your exams, but this, how do you do it? So simplify it for the patient. Use layman terms. Do not include technical jargon. Be empathetic while telling them for the first time what they are going through, what is their diagnosis, especially if it is not a diagnosis that they're looking forward to. Go gradually, go sequentially, involve the relatives, give them time, make them sit down somewhere, solve all their doubts once you've told them about it, give them the treatment options, make them a part of the team, the investigation team that you are a part of, because it is you against the disease. It is you and the patient on one side and the criminal on the other. Thank you.
Thank you, Dr. Pooja, for that very remarkable and interesting perspective on how to make a diagnosis. I just love the way you liken the clinician to a detective, who puts together all the clues to finally reach the conclusion. So thank you. Brilliant talk. You brought out some very relevant aspects that every clinician should keep in mind when making a diagnosis. And I'm sure it is going to benefit the PGs in their exams if they keep all these pointers in mind. So with that, let's turn to our discussants for any key takeaways, any practical tips, or any piece of advice that you would like to offer our postgraduates after this talk. So I'll start with Dr. Alka Gupta, ma'am. Dr. Gopal Pillai.
Hi, ma'am.
What would be
It's
your
a very interesting perspective here talk. So basically, a clinical case presentation means that, over a phone, you are basically talking about that patient to the other side. And just by hearing that, that final summary of diagnostics, that only we should be able to come to a proper thought process as to, what is it that we are looking at? What is the severity of that? What is causing that? And how best we would like to always manage. I would probably also just add, because it is very comprehensive, I would also just add activities of daily living of that person. So, which would mean like what would be his visual needs as far as ophthalmologists are concerned, what is his visual needs? And that probably also has a lot of importance in deciding the treatment to the patient, whether to do a surgery, whether not to do a surgery. So probably activities of daily living makes a huge difference. An 80-year-old grandmother versus a 35, 40-year-old person, the visual needs may be completely different. That is one point. Then another point, which is that, there is a little bit of a distinction between when we are looking as a postgraduate and as an undergraduate, because we are teachers for both. So we need to customize it to them. Generally, for an undergraduate, we would say that all the symptoms and signs, probably should be explainable by a single diagnosis. Whereas we know that many of our patients may have cataract, may have glaucoma, not secondary to cataract, but because of another etiology, and may have diabetic retinopathy, and may have some other problems as well. So multiple diagnosis and multiple primary diagnosis may be definitely there in some of the patients, at least at the postgraduate level. They should understand that. These are the 2 points. Very interesting talk, ma'am. I think Sherlock Holmes would be proud.
Thank you, sir. And yes, you're right. That's usually what also my students ask me. And when there are two primary diagnoses or two diagnoses that need to be tackled, like the diabetic retinopathy and cataract, in that case, each of them should have their 5 parts by themselves, or so that they can tell them detail. Yeah. Thank you.
Dr. Rakesh Purwal, sir, would you like to offer any comments?
Good evening, ma'am. The most important thing, I would like to congratulate ma'am for such a beautifully designed way to make the resident understand how to write it. I would really congratulate ma'am. The most important thing about the study was, by the presentation, was that every diagnosis should have a primary diagnosis and as well as a secondary diagnosis. The most important thing is that your presentation, your diagnosis serves your personality, that how much you are worried about the patient diagnosis and how much line of treatment you would plan for his treatment and his surgical part. I would like to add two, three more important point in this study is that I would like to use that language only which the patient like. Suppose the patient is talking in Hindi, I would like to talk in Hindi. If the patient is in English, I would like to talk in English. The second thing is about the attendant. I would always like to take the history in front of the attendant, because many of the time the patients coming to us are very old. So we would like to have an attendant because the attendant is well versed and he would like to talk to us very nicely. The third thing is I would like to add is please like to see the old records, all the records of the patient, because most of the time now the patients are showing to many doctors. So the old record will always serve in helping you out the diagnosis of the patient. And the fourth is that what are the medicines he is putting and what are the glasses, whether he is really comfortable right now with his glasses, he want to change for his glasses, or whether he want to go for surgeries. Just a point to just a ponder. So the most important thing, the important is the old records, medicines he is using, and the glasses which he is wearing. The most important thing other than that is that most of our residents, they are just writing mature cataract. This is not the right thing. They should have a comprehensive, complete diagnosis which make and show that the resident has completely attended the patient diagnosis right from primary to secondary. Hats off to ma'am, and thank you, Tinku ji.
Thank you, sir.
Thank you.
Another thing I'd like to add to that is that non-verbal clues are also extremely important. It's just not taking the history from the patient, but also observing him, how he walks in. There's so many non-verbal clues that you can pick up while making your diagnosis. So, any inputs on that, Dr. Pooja? The non-verbal.
Yes, Dr. Tinku. For example, this is how we always train our students, that when the patient comes in, he has come in from the refractionist room, from the refraction room, and from the time he enters your room till the time he even sits down, you can diagnose so many things. Like, does he have a field defect? Does he have a searching look? Or is he tense, or is he a type A, the way he is talking to you or she is talking to you? Does he have so many relatives with you? So there's so many components of the diagnosis you can make even before the patient sits. Sometimes you see that the patient has a high BMI. You can make it out before he sits, and you will realize that maybe he could be having diabetes, or he could be having other hypertensive or other issues related to systemic problems. So there are many things, including visual fields, including the searching look, including the blindness, including his type A personality, especially when it's related to CSR or something like that. There are many things that the patient gives away. Sometimes he's not looking at you directly in the eyes. He's hiding something, and then you maybe need to talk to him separately. There are many of these clues that need to be looked into. Thank you for that.
Thank you. Thank you so much again for that very brilliant talk. And with that, we move on to our next speaker. Just share my slide. So our next speaker is Dr. Sahil Bhandari, who is a consultant at the Guru Hasti Netra Chikitsalaya at Jodhpur. So he's a senior cataract and vitreoretina consultant there. To give you a background, he did his MBBS from the Government Stanley Medical College and Hospital, Chennai, and a diploma in ophthalmology from the Madras Medical College, Chennai. He went on to do a DNB in ophthalmology from the Arvind Eye Hospital and Postgraduate Institute of Ophthalmology at Pondicherry, and followed that up with a fellowship in vitreoretina from the same institution. He's also done an FICO from London, and he's also certified by FAICO. He's a very skilled eye surgeon, a healthpreneur with expertise in clinical eye services and community ophthalmology. So at present, he's running a 100-bedded charitable eye hospital, which offers a high-quality, low-cost treatment to the rural population of Pipar city near Jodhpur. So that's a very commendable effort. He is he's an expert vitreoretina surgeon and also an anterior segment surgeon. So with that background, Dr. Sahil Bhandari, it's my pleasure to introduce you, and he will be speaking to us on the stepwise analysis of imaging techniques. So over to you, Dr. Sahil.
Thank you, ma'am. Thank you for the kind words. I shall
Gotcha.
share my screen. So the topic of presentation today, the screen, the presentation is visible. Yeah,
It's
sure.
visible. It's visible.
Okay. The topic of presentation today is the stepwise analysis of imaging techniques. Now, when we talk about imaging techniques related to eye, there are multiple imaging techniques like fundus fluorescence angiography, indocyanine, corneal topographies, OCT of anterior and posterior segment, and fundus autofluorescence, infrared imaging, ultra wide field imaging. So obviously covering each and every topic, each and every imaging technique will not be possible in a single way. So what I have concentrated today as a veterinary surgeon is more of the coverage about the OCT macula, OCT disc, then central corneal thickness and angle OCTs, that is anterior segment OCT, and fundus photo, infrared, and autofluorescence, which is in the form of correlation of these three with the OCT findings. So when we talk about step-by-step analysis, so the mainly analysis is dependent on the report which is generated at the end of the scanning. So once the scanning has been done, which has its own error, maybe patient-related error, the software-related error, or even the technician who is doing the error, there may be some errors out of it. So that may be or may not be visible directly. But when we analyze the report, that helps us point out that whether the report is reliable, is it partially reliable, or it is completely non-reliable. Do we need to repeat the imaging? Do we need to give a diagnosis based on that imaging, or do we need to correlate much more with another imaging technologies also or not? So moving on to the OCT of the macular area. So when we talk about any imaging, there are multiple machines which are available. The OCT, there are multiple technologies, multiple companies which have come out with different kinds of machines. So not every machine will have the similar reporting pattern, but the sections of the reports are almost the same in most of the machines. So what the imaging technique which we have at this point of time in the charitable hospital, I'll be concentrating on that, and I'm pretty sure that it will be easy to correlate with the other imaging reports which we get in different kinds of machines, different companies of the machine. So when we start with the reporting, we first look into the patient parameters, the scan parameters, the signal strength of the whole of the report or the whole of the images. There will be a fundus infrared image in most of the reports. Then there will be a colored, which is more of a pseudo color thickness map with a scale around it. Then there will be a kind of B-scan image of the OCT macula. And finally, there will be a central thickness map, which will be at the 1 mm, 3 mm, and the 6 mm diameter of the macular area. And finally, there will be a summary of the parameters, which will be related to the, again, the thickness map, which is a more of a retinal thickness map. So we'll go one by one into the sections. Coming up to the parameters, first of all. So parameters have two parts. One is the patient parameter. The second is a scan parameter. So when we talk about the scan parameter, when we talk about macula, there will be multiple types of scans. Commonly is the raster scan. Other than that, there could be a square or cube scan. There could be a radial scan. There could be a this is the raster scan, which has some scans have multiple lines. Some have 5 lines. So this is a 5-line scan. It can be a raster scan. This is a radial scan. This is a cube scan. Another one which we also have in many of the machines is a cross scan. So there are 4 lines in horizontal and 4 lines in vertical. That is a cross scan. So first of all, you need to look into the report that which kind of scan is it? Is it a raster or some other scan? What is the length of the line? Is it a 9 mm or a 12 mm? 9 mm generally covers the macular area, and 12 mm cover both the disc and the macular area in one go. Then is it single eye scan or both the eye scan are in the similar report, same report. Then when we come up to the patient parameters, it is the name of the patient, gender of the patient, date of the birth or the age of the patient, and obviously the ID, and who has done it and who has reported it. Then the time and the date. Why all these things are important? Because most of these machines always have sorry, ethnicity I missed out. The ethnicity is also important, whether it is an Asian, Indian, whatever ethnicity. Why all these things are important? Because first of all, you need to know that whether you are reporting the correct patient or you are reporting the wrong patient. Secondly, you need to know whether the data entered by a technician or you one of your juniors or any resident who has done it, is it correct or not? Third thing, it is going to compare, the machine is going to compare the normative data which is stored in the machine will compare it with your patient, whatever scan you have done. So if the date of birth may be wrong, or the age is wrong, or ethnicity is wrong, or even sometimes gender, it is wrong. So the normative data will be compared in a little bit in a wrong manner. So you need to be sure. Then the time and the date. Obviously, you need to look whether how old is the scan, how recent is the scan. Are you going to compare it serially? If you have 3 to 4 scans, then you need to place them serially in front of you and then compare them. And how is it going? Obviously, one single report as a proper doctor, as an ophthalmologist, you do not rely on the single report. But yes, we are talking about at present the step-by-step analysis. So we will be having only a single report in front of us. Then coming up to the signal strength and the infrared images. So the signal strength denotes that how good the penetration of the infrared rays is there. So if the signal strength is good, 4 or 5 out of 10 or 6 or 7 out of 10, that means the penetration of the rays is better, and the report which you are getting is much more reliable as compared to the low signal strength. Some images give signal strength like SSI. Somebody gives like QI, qualitative index. Whatever it is the marker that how good the scan is, how good the penetration of the infrared images, infrared rays is there. Then this image is a kind of infrared image. In this, it shows that the raster scan, where is it has been taken from. You can increase the illumination, infrared illumination in some of the machines, and you can see the actually black and white fundus over here. And this the superimposition of the cube, of the raster scan and of the circular radial thickness map. And finally, this yellow line depicts that the report which you are having, the printed report, in that the B-scan images, that is the image of this particular line. If it is up or if it is down, or you can take particularly, if you are interested, you can obviously move the cursor, move the line to one of the particular segment and print it out, so that you know that which area you are trying to analyze. Because many of times, like diabetic patient, hypertensive patient, they may not have the central foveal thickness, central macular edema, but they may have a paracentral edema, parafoveal or a perifoveal edema, which may need to be treated with a grid laser or a focal laser, something for the front of you. So in order to analyze that, you may have to move the cursor over there and look into that particular thickness. Then comes in the thing is about your color coded thickness map. All these color coded map are surrounded by a image, a scale. Scale shows how whether it is thin, it is in the blue range, it is in the green, or it is a thicker range, that is the red. Remember, these are all pseudo colors. They have been given for our comfort and to explain the patient that what is the severity of the thickness. The red side is more thickness, green side it is a green or blue, it is on a normal scale. This thickness map can be correlated with, some people may have some machines will give you a this is a kind of retinal thickness pseudo colored image. So whether it is green, red, or a kind of bluish one, which is denoting a thinned out area. So you can again explain the patient, and you can even follow up the patients. Whenever you have multiple scans, you can understand the diameter of that particular red area or thickness area. Is it reducing with the treatment? Is it increasing with the treatment? Is it migrating sometimes? So those all things can change. This is a comparative analysis. Comparative analysis in the sense that you have right eye and left eye side by side. You look into that image, the retinal thickness colored map. You look into the raster and infrared image. You see whether the image has been taken from the correct area, your area of interest. Is it properly centered or not? Is it decentered or not? Is it covering your interested area, or is it you need to again mobilize it to that particular area of interest and then recalculate it? Sometimes you may have artifacts, such kind of this like a valley like thing or a river like thing. This area is a kind, it is not a thinned out area, rather it is a movement artifact. Maybe a small movement or eye movement would have happened during the scanning image. The scan was taken correctly. It was taken from the right area. It was taken properly, but a saccadic movement, a small movement would have happened, and the area which was normal in thickness has moved from one area to one area or to another area and has led to overlap. So you need to be cautious about this thing, that this area is wrongly evaluated. So you cannot say that this from this area to this area everything is thinned out. You may have to correlate with the B-scan images. You have to move the cursor to that particular area of interest and then correlate this with the infrared image and see whether actually that area is thinned out or this is a pseudo imaging. The central area, this is a comparison, like this is the thickness difference between the right and the left eye. Now we come to the B-scan images. Obviously, they are both pseudo-colored and grayscale. Many of us like to analyze it in a grayscale because somehow it gives much better contrast. But the reporting printout generally come in a colored image because that gives patient a much better image in understanding. It is easier for the patient to understand. But when you come up to a grayscale image or a colored image, whatever it may be, you need to analyze from the top to bottom, the inner to outermost areas, inner to outermost area, temporal to nasal. You have a location over here which shows this image has where is the temporal area. So this side is the temporal area. It is going towards the nasal area. Similar, this A-scan is the opposite one. This is the nasal area going towards the temporal area. So you know that this dip is related to the optic disc. This dip is related to the optic disc. This is the central area, parafoveal area. Now, we are not going into much detail of the thickness or thinness or the pathological diagnosis because it is more related to the stepwise analysis of the particular image. How do you analyze this in a stepwise is you see whether this vitreous area, how good is it? Is there any thin membrane like hyperreflective membrane or not? If it is there, it could be a posterior vitreous detachment. It could be a tractional image. It could be a VMT, vitreomacular traction. Or it could be a taut posterior hyaloid or a detached hyaloid. Then you go to the 10 layers of the retina. Whether all the layers are proper, is there in thinning in certain area or not? If it is thinned out, then the same thing can be taken into the colored image and you can look whether it is the only inner outer segment cone rod photoreceptor thinning or it is the diffuse thinning. So do we have all the layers which are lost out, or we have only certain layers which are like outer retinal layers or only inner retinal layers? So that way you need to analyze and then you have to come to a particular diagnosis as we need to do from a reporting point of view. These are other color coded maps. You may have in certain reporting, or you may have to select a certain report like ganglion cell thickness, inner plexiform layer thickness, a combination of it, or RP deformation map. So if you want that particular thing, you may have to select that particular area. You have to select that particular report format, and then when you print out, you get all the information out of it. It is the retinal thickness. Again, as I said, it is the color coding. You need to be sure that the color coding which is being depicted, the scale which is being depicted, is it a percentile scale or is it a thickness scale? So this is a percentage scale. So in this, when we go into the red area, It means that most of the normative data, I mean, most of the normal patients do not come into this range. They come into 55 to 95% of the patient or the population or the normative data should be within this range. So when we talk about 0 to 1%, so when we have an area which is red marked, it means this area is an abnormal area which is normally not which is not a part of a normal patient. It is mostly into the less number of patients. So the prevalence or the incidence of this area being an abnormal is a very on a lower side, and obviously there is some kind of pathology which is going on in that particular area. So red area is marking of that part. Then the surrounding is the yellow area, which is also to be found in a less number of patients. That is 1 to 45% of the patient only you can find. So you are correlating your own particular patient with the normative patient. Is that particular area abnormal or is it a normal? Same. Now, when we go to this thickness, this is in microns. So again, here red means is a thickened area. When yellow and green, when we talk about green, it is a normal area. Yellow also would be a normal area. Then the same thing is compared in right eye and the left eye. These are all again color-coded maps. You need to see whether you are dealing with a thickening, whether you are dealing with a thinning, whether you are dealing with a normal thickness. Then again, quantitative parameters. When you have summarized all these things, whenever you analyzed multiple other scans, other color-coded maps, other B-scan images, then you come up to a data. This is the right eye data. This is the left eye data. The central area is 1 millimeter in diameter. The second circle is 3 millimeter in diameter. The third circle is 6 millimeter in diameter. So when it is centered on particularly fovea, then you see that the surrounding the fovea, the 6 millimeter diameter area has been covered up, and it has been divided into 4 quadrants. There is superior, inferior, nasal, and temporal. And each of these value is an average of that particular area. It is not the single value. So it is, mark my words, it is not the single value. It is the average of that area. So just looking at this thing, you cannot say that there is abnormality. This 280 as compared to 225 does not mean that the left eye is abnormal, or it does not mean that the right eye is thinned out. Obviously, you need to analyze the B-scan images, the gray and white scale, the colored maps, thickness, and then you have to come out to the interpretation. To help out that, okay, there are what kind of parameters it may be. To evaluate, not just to evaluate, also to follow up, to prognosticate, or you may have to compare that what was the last scan, what is the thickness after you have treated with whatever modality it is, that whether it has reduced, whether it has increased, whether it is maintained the same, whether it is responding to a treatment or not. So these thickness map, along with the thickness map, these summary parameters can help you out, which may be variable as per the machine. In this, it is average thickness, that is 256 is the average thickness. Now see, when we are talking about 256, it becomes very confusing. We don't find any 250 range data over here. So it is the overall thickness, overall average of the 6 millimeter scan, which has been given over here. Foveal thickness 226, which is matching with 225. So that is the foveal thickness. That is again the average thickness. When you're talking about center thickness, then there it is pointing to the foveola area. So that foveola area has been scanned, and again it has given an average area. Superior thickness, again the superior means this superior particular quadrant, average thickness. So that comes around 255. Then inferior thickness, that comes around 255. So that is the average of these two areas. The superior is the average of these two areas. So these all things are average. The same thing, some other image like Zeiss machines give this kind of analysis. This is a Huit's machine which is giving this kind of analysis. Zeiss machine gives this kind of analysis, and it shows that ILM, ISOS, RP measurements. So minimum in fovea, the minimum thickness in fovea is this 168. The central area is 223, which is showing this area, which is a 1 millimeter scan, then 3 millimeter, and the 6 millimeter scan. This graph is available not on every machines, but it is a graph which is showing the, which is scanning this whole B-scan image and showing you the graphical representation, whether the graph is within the green range or is it going into the red range. Red range means pathological range. Last, related to the OCT macula, obviously you need to be aware of the multiple errors which can arise. Like in this is a left eye scan. This is a patient related movement artifact or a blink artifact. You can see these kind of lines stretching out here from the vertical to vertically. It means the patient has moved the eye or there has been a blink, so that it is kind of overlapping. One particular area has overlapped the other areas. So you cannot very well rely on these this particular report. You need to think and you need to maybe probably repeat the scan, or you may need to go and move the cursor up and down and then scan, look into that particular area which of your interest. This is a shadowing. You can see the central area is clear, the side area is gone. So this could be a shadow because of maybe some kind of opacity all across from anterior to posterior area. It can be any kind of opacity. It can also be reverse, vice versa. I mean, the central area may be hazy and the surrounding area of the OCT may be clear. This generally happens in your posterior subcapsular cataract, posterior polar cataracts, because that is the central image, the central shadowing effect. So that, or it may be a central vitreous hemorrhage, something like that, of that sort, which is causing a shadowing effect. So you need to again look into it clinically. Then software related problems. What are the software related problems? Majority of the software related problems is a segmentation error. Why is it a segmentation error? Because obviously when you have the machine has been taught that this is the ILM. The first area of hyperreflective layer is the ILM. The last hyperreflective layer will be the RP, and you have to, in between the hyperreflective layers will be ISOS or inner praxiform layers or something like that. So that segmentation machine does as per the learning. That is an artificial intelligence kind of thing. But when the layers are disintegrated or there are multiple tractions, then you may find some or the other issues out of it. So segmentation errors may happen. So again, due to the segmentation error, you can go into the machine, you can click into the segmentation, it will show the segmentation, which will be easier for you to understand that what is the segmentation. This is the misalignment error. Obviously, your area of interest is over here. The cube is over here. However, the raster has gone to there towards the correct. But when you pull it towards this area, you can pull the cube towards this area. It will give you a better analysis. Again, this is for a practice session. Let's go again one by one, step by step. Quickly, we will try to cover it. Scan parameters. It is the raster scan. How much millimeter? 9 millimeter scan. Parameters: patient name, ID, date of birth, gender. Is it correct or not? Date, time. Is it correct or not? Is it both eye? Single eye. It is both eyes. This is the right eye scan. This is the left eye scan. Is there any error which you find? Either a movement artifact or blink artifact, or the scan is decentered or not? Yes, this is decentered over here. So you may have to pull it towards the right area, the area of your interest. Then only the evaluation, the further analysis will be correct. Then we come up to the B-scan image. Is the B-scan image centered on the fovea or not? This does not appear to be centered on the fovea. It is a little bit parafoveal area or a perifoveal area. So you may have to move this yellow line towards the foveal area so that you can get the B-scan image over here. Then again, is this is all centered on the fovea. Why is it not straight? It is on a curved manner. So it could be a myopic patient. A small staphylomy may be there. Because of that, it is more of a curved image. Now we are analyzing. Now we will come to the thickness map. When we come up to the thickness map, central area is this. This shows that 374 is the central thickness. But then you come up here, you match it whether your area of interest actually it is centered on the fovea or not. If it is it is centered on the parafoveal area, there may be a parafoveal thickness. So that is the reason it is giving a thickened parameters. It is giving 374 thickness. It may not be that. So you need to again look into the B-scan image, center the macular thickness cube, the circle on the fovea, and then come up with the new readings. And then you say that yes, it is thickened or a normal one. Same way here, it appears to be thinned out. It may be thinned out, as compared to normative data, it may be thinned out. But when you see the B-scan image, you see that almost all the layers are correct except the ISOS layer, which is a little bit on a thinner side. RPE appears to be all normal. Black and white image also shows your central ISOS as a normal image. So it means that anatomically most of the things are normal, but maybe because of age-related findings or a myopic degeneration or a pathology, a high myopic patient, the ISOS has started to disintegrate or has become thinned out. Due to this, you are getting this thinned out report. This is again another scan for your analysis. This appears to be well centered in both the eyes. The central foveal area has been scanned. Here also foveal area has been scanned. So overall, if we look into the thing, there is only one problem here. This is the area which appears to be abnormal. But when we look into the raster scan, that why it is thinned out, then we will go and then we will move this cursor. Finally, we are able to see that yes, actually it is thinned out. So it is not that this is completely abnormal. It is actually that the area itself is thinned out. All the layers are disintegrated. All the layers are showing thinning. Here, all the layers, there is a obviously subretinal fluid. There are some exudates kind of thing in the retinal layers. So it is showing thickness. Yes. So everything appears to be correlating. This red area also appears to be thickened because it is correlating between the 400 to 500 micron thickness. So overall, we can say that this is the central macular thickness. This is central macular thinning. Well, I hope things are clear related to the OCT macula. Keep posting your questions. We will try to answer them. Now moving on to OCT of the optic nerve head. I'll again brush up with the common parameters. We'll move out first. Only thing we need to look is there a 3D analysis of a disc, or it is a circular scan, or it is a radial scan. Most of the time when we want an RNFL analysis, it is the 3D imaging of the disc. Other parameter, patient parameter, as previously discussed about. This comes again the signal strength over here, and this is the disc infrared image. It is very important when you get this kind of image because this will give you a very good idea whether you are dealing with a reliable scan or a non-reliable scan. You may have segmentation errors here, over here. You may have misalignment or a movement artifact. It means this disc may be appeared like it may half cut, or you may find some black lines or white lines over here. If you can look over here, this area, this particular area in specific, you see that is a wavy light thing. The whole of the blood vessel is not continuous. It is getting dissected over here, then again, then again, then again. It means there was some kind of blink or some kind of movement while the scan was going on. So this particular area, the inferior part of the disc may not give you a good analysis when you go to the RNFL thickness map. So you need to be aware of this part that yes, there is some kind of blink artifact or a movement artifact. So the complete analysis may not be reliable. But over here, you see that most of the scan is good. It is centered on the disc. The 3D scan is centered on the disc. Is the image is clear. There are no artifacts. There are no errors. The most important part of the optic nerve head analysis, whatever machine it may be, whether it may be GDX, it may be scanning SLO, it may whatever it may be. So you need to look into the RNFL analysis map, RNFL thickness map, which can be color coded, which can be a comparative as compared to normative data. It can be an average of 4 quadrants. It can be clocker average. So these all things will give you an idea that how good the RNFL thickness is. Again, all these color-coded maps are surrounded by the scale. So you can very well see that what the scale means. It is there is only one small catch about it. This first image and the second image has a vice versa color coding. It means the red over here is on a normal scale. It is a thick RNFL. It is a good RNFL. But if you see red over here, that means it is into the abnormal area. So it doesn't mean that red hair is an abnormal. No, the red hair is on a normal scale. But if you find some reddish color coded over here, it means that RNFL area is thinned out rather, because that is generally found out in between. That RNFL thickness will be available or will be interpreted between 0 to 1% of the patients. So means that is an abnormal RNFL. So here you can see in this first and second image, both right and left side, you can see that here when all the thing is red, here nothing is red, because this red is in the normal thickness scale. So that means it is a good RNFL thickness. It is a normal disc RNFL thickness. The same thing is reflective here. Again, the age-old ISNT rule will be followed. Inferior, the thickest, then superior, then the nasal, and then the temporal. Nasal and temporal generally will have a little bit variation, but this follows the ISNT rule in both the sides, right and left, both the images. Again, as I said, that there appears to be dissecting lines over here. So the analysis is not completely reliable, but still it is not completely unreliable. And everything appears to be green. So this green and red is mainly for the patient satisfaction, patient explanation that, okay, you need not worry about it. Everything is on the greener scale. It is not on the abnormal side. But you may need to follow up, or you may need to undergo and treatment depending on the clinical evaluation. This is a very important graph, which is the TSNIT graph, which is RNFL graph. Again, it gives the right and left eye comparison. Some machines give right eye separately, left eye separately, and both the eyes overlapping. So again, here inferior is thickened. In this, whatever it is in the green area is normal, yellow area is borderline, red area is abnormal. And this is the summary of optic nerve head analysis. This is optic nerve head analysis. Is it gives your RNFL symmetry. Symmetry means superior, inferior, nasal, temporal. It will give you average parameter. It will give you the vertical and horizontal vertical ratio of the CD. So cup disc ratio, again, we highlight that part only. We'll mainly concentrate on the cup disc ratio, whether it is matching your own clinical evaluation or not, whether it is matching your clinical evaluation and your HFA parameters or not. Other things generally is like we do have the parameters, but then only when you have a serial analysis, serial imaging, then you can see whether there is thinning, there is normal, is it going on, going in towards an abnormal scale or not, or is it maintained with your treatment. For an example, TSNIT rule. This is again TSNIT map. See, you had two kinds of peaks. One is blunted peaks. Blunted peaks means it is thinned out. Inferior thinning, superior area thinning, nasal area appears to be in the greener scale. That means it is on the normal scale, normal thickness map. But both the inferior and the superior area have the peaks have blunted in both the eyes, right eye again and left eye also. So both the peaks have blunted means both superior and inferior RNFL thinning is there. But sometimes there are some thing called as shifted peaks. It means the thickness is in the green part, but it is not in the normal area. It has been shifted. So this superior peak of the particular patient in both the right eye and left eye has shifted on the left side. But that does not mean again it is abnormal, because it is in the greener segment. The thickness is correct, but it is not matching with the normative data, because it may be due to some altered anatomy, it may be some tilted disc, it may be a myopic disc, it may have some kind of abnormal optic nerve head insertion. So because of that, the machine is analyzing correctly, but the areas are a little bit different as compared to normative data. So this is a time for second revision. Revision in the sense, the optic nerve analysis which we have done, we are looking into an example, whether it is correct, it is reliable, non-reliable, is it thinning, is it thickened, or whatever interpretation you can come out with this particular image itself. Okay. And now, though we look into this thing, this is the thickness. The scale is around 4, signal strength is 4 out of the 10, which is okay. It is not bad, it is not good, but it is okay. You see all the reddish area, you compare it, you see that this cup appears to be very much enlarged. This light gray area is the cup, and the dark gray area is this neuroretinal rim. So neuroretinal rim appears to be thinned out. The cup appears to be enlarged. Again, as I said, the second image and the first image have contrasting colors. Here you don't see any red image, red color, but here you see most of the areas are red color because they are thinned out. They are found out in between, they are found between 0 to 1% of the patient. Then again, it is matching over here. This is the right eye, then red color is the left eye. All the images, all the peaks are blunted. Most of the peaks are blunted, whether it is inferior segment, whether it is in superior segment, which shows that yes, most of the areas are thinned down. Now it is more blunted in left eye as compared to right eye. So left eye is showing almost all the areas are thinned down. So there are changes which are glaucomatous changes, which are more in left eye as compared to right eye. Here in right eye, you find that there are some blink artifacts or a movement artifact. Though it is a little bit less reliable, because why we are saying this thing is because left eye is showing a good amount of glaucomatous changes, but right eye is not showing that much because of the, it may be because of the blink error. So you may need to repeat it. This is an OCT nerve RNFL and optic nerve analysis from another machine, which is mostly a Zeiss machine. It gives like signal strength 7 out of 10. Again, same thing. The red, this color and this image, they will have your contrasting colors. Here more of red, less no red. It means again it is in the normal range. It gives right and left eye analysis. Left eye, most of the find areas you find that these are black color lines. So most of most of this scan is not reliable. There are movement artifacts, there are blink artifacts. So right eye you can rely much. Left eye you cannot rely much. You have to judge it on the clinical basis, and you have to tell the patient that yes, it appears red, but the clinically it is on a different way. So we come up to the end of two things. That is, one is OCT of the macula, stepwise analysis, and OCT of the disc. This I will brush up. I'll try to move fast because not much analysis we do on OCT. Like it's not a very detailed analysis which we saw in the optic nerve analysis or RNFL analysis. This is a central corneal thickness map. You see whether it is done properly or not. First of all, is the image correct? It is bright or not? Is it everything green, or are there any reddish shadows or not? If there are red areas, means there are thickened areas. This is a keratometry evaluation. This is the central corneal thickness mapping, CCT mapping of the central area. Central, again, it is 6 mm. Anterior radial scan with the 6 mm. So this is a 6 mm central corneal thickness map. This is the keratometry. Remember, it is showing in 4, 4.5, 6.5, 7.5. These are the millimeters. We generally see keratometry index in diopters. But when we convert it into millimeters, this is the range. Again, here, the keratometry index is symmetrical, smooth. This is another image. What is the difference between the first, this image, and this image? A simple difference. This line scan, this is the white color line, white color shadow. It is the shadow of the software or the machine. So somehow it is giving a high shadow. Because of this, you may not be able to evaluate the central area if you want to actually measure with the caliper. So you may have to repeat the scan so that this shadow converts into something of this shadow. See, here you can see a bright reflection, but it is not superimposing your corneal map. It is not superimposing corneal map. So if you want to measure the central exact thickness with the caliper, you can very well measure it in this image, but not in this particular image. So both the images are normal. Everything is good. Thickness is good. Everything is good. Here, what is the problem over here? Again, here only right eye is all good. No issues. Again, a little bit of hyperreflective line over here. But look over here. In this nasal side of the left eye is showing some kind of thickness. This keratometry map is showing some kind of abnormality. It is not smooth. It is not symmetrical. Here, when we look into the B-scan image of the cornea, we see some thick area which is in the superficial aspect. I mean the subepithelial stromal aspect, superficial stromal and subepithelial. What could it be? As Pooja ma'am said very clearly that you are finding something. So this is very good. finding which you have pointed out, and you are saying that there is some kind of degenerative tissue or some kind of abnormal thickened tissue which is going, or it is penetrating the stromal layers of the cornea, which most probably is going to be a nasal pterygium. This area, this map. Now, again, when we talk about the right eye scan is good, but look over here. This appears to be a little decentered. The eye appears to, eye is over here. The limbus is from this area to this area, but this map, the radial scan itself is decentered. Here again, the radial scan is little bit decentered inferiorly. This is decentered nasally. So all the images, all the reports are not reliable into it. It is showing very decentered image, very asymmetricity. Why I have pointed out this images? Because when we look into the corneal map, it appears to be normal. Grossly, it is normal. Here, it is abnormal. Yes, it is abnormal. There is some kind of degenerative tissue. Again, why? See, it is, since it is decentered, so it appears that most of the scan was done on the pterygium surface. So this is the pterygium which is continuously into the subepithelial degenerative area. So it is because of this, you are having abnormal thickness. This is 638 thickness. You are having asymmetricity in the keratometry values. Here, this is in right eye which I am talking about, because of the pterygium and the decentration of the scan. But in left eye, not just the decentration, but the image has not been taken properly. The optimization or the focusing of the image is not correct. So this left eye needs to be repeated properly, and optimization and the focus has to be done properly. In the right eye, the centration has to be done properly. Moving up to angle OCT. Well, remember, most of the machines now which are having angle OCTs, they have a single scan, single area. I mean, you can only scan either the nasal angle or the temporal angle. Both the angles generally do not come together. The Visante, which came in the beginning, it is the Zeiss machine, that gave most the single line scan. Now machines have an upgradation, that is they give 16 mm scan. In that 16 mm line, you get both the angles together. In this angle, what are you analyzing it? First of all, you are looking into reflection saturation beam, which I said that should not be very high because it will superimpose your images. Then you look into the scleral spur. What is scleral spur? Scleral spur is a ending of a hyperreflective area, which is the of the corneal area, and that converts into the hyperreflective zone. So that is the scleral spur is the insertion of your ciliary muscles over there. The angle parameters over there. This is the iris. This is the anterior lens vault. This is the anterior lens capsule, the ALC, anterior lens capsule. And when you talk about lens vault, you draw a line from one iris to another iris. These are all again evaluation for the evaluation purpose for your angle evaluation. So when we go to a particular angle, you need to know the measurements. So measurements have their all denomination, like angle opening distance, angle recess area, trabecular space area. You need to first point out the scleral spur. So as this green dot is there, this is the scleral spur. You mark it with the caliper available in the machine. Then you draw a straight line from this, which is parallel to your inner corneal surface, and go up to either 500 microns or 750 microns. So when you go up to that area, you draw that area. Then you again mark it from their area. Now I'll just describe these three parameters. Angle opening distance. Angle opening distance is a single measurement, single line measurement. How are we reaching onto it? We have already drawn this particular line, which is parallel to the inner corneal surface. You identify the 500 micron distance from the scleral spur. You go up to 500 millimeters distance, and from there 500 millimeters, you just draw a perpendicular line over here. And when you draw a perpendicular line, the distance, it will end up, where will that line end? That line will end just at your iris surface. When it ends, whatever the distance is showing you in the caliper is the angle opening distance. It is not the angle, not the degrees of the angle. It is angle opening distance. So in this image, it is 373 millimeters, which come microns. If you go into micron, it will be 300 microns. And at the same thing, at the 750 microns, it will be 553 microns. So this is the white color is the 750 micron. It is all caliper based measurements. So you'll have to use the caliper available into the machine. What is about what? Now when we, that is the distance. Now next is the area. Area is a triangular area. Triangular, this triangle itself is showing you. One line, triangle has three lines, three borders. One border is the inner corneal surface. The second border is the perpendicular distance. The third border is the straight line which joins the surface of the iris to the scleral spur. So this triangle is the angle recess area. Again, one more area, which is trabecular space area. This is a trapezoidal, means there will be four borders out of it. It is not shown in this in particular image. I could not get the image out of it, so I'm just showing you the image which is available with me. Where is the fourth border? The three borders are very clear over here. The three borders are very clear. Now, the fourth border is the simple one. That is the, you will draw a line which will start from this scleral spur and it will go perpendicular to the opposing iris. It will go from here to this particular iris surface. This will be the first line. The second line will be joining this particular area point to the surface of the iris, the highest surface of the iris. So it means this particular line will little bit shift over here. So this one particular line which adds into it is the fourth border. So that particular area is the trabecular surface area. So this is all the angle areas. I think these all gives measurement. When they give measurement, it will show you the angle, this scleral spur angle. So this is 37 degrees. Finally, when we do all the measurement, we concentrate on whether it is 18 degrees, 20 degrees, 40 degrees, 35 degrees, 10 degrees. So if it is less than 20 degrees, it means it is narrow. More than 20 degrees, it means it is normal depth. If it is more than 40 degree, it may be a recession, angle recession may be there. So because of the trauma or any other cause. So actually four things which we have covered: macula, disc, central corneal thickness, angle. Now last, fundus photos and its correlation with the autofluorescence and the infrared images. This is a fundus image. You may have one eye, or you may have both the eyes in one image. How do we analyze it? Obviously, we look into the clarity of it. We see whether it is centered on the macula or not. Fundus photographs can be taken in two ways. It can be centered on the macula. It can be centered on the disc. This per se is centered on the macula. You may choose the option in the machine, and this particular will come in the center. So that is more important when you are looking from the glaucoma perspective or point of view, or optic disc evaluation point of view, maybe because of edema, AION, NAION, anything of that sort. This is again a combination of the color photograph and the infrared image. Remember, this second image is the infrared image. Why and how? First of all, why? Because infrared can give you again a black and white impression of it, and you may get a little bit few additional findings out of it, because there will be a more penetration, because infrared will penetrate the RP layer also and give a reflex of the choroidal areas, choroidal layer. How do you identify whether it is infrared or it is autofluorescence? Well, a very simple thing. In the infrared, this disc appears a little and it appears bright. When you go for autofluorescence, the whole of the disc will be jet black. It will be black, which is seen also in indocyanine green angiography. These are the three images to compare with. Well, the central image, if you see, when you evaluate a fundus photograph, you say it is centered on the macula. The disc, whether it is border are seen or not, whether there is any kind of white tissue or not, whether there's the arteries or veins are seen properly or not. In this, you can see the arteries are narrowed out, veins, the caliber of the veins are reduced, the disc borders are not very well made out. There's some kind of fibrous tissue which is out of the focus. It means it is somewhere in the vitreous area. Again, then we want to see whether infrared image is we are able to compare it, that the border, the white tissue is passing on from the disc to that particular area. Again, you may get in OSCE, you may get some fundus photographs and you may have to describe it. So you will have to describe with the clarity, whether the media appears to be clear, media appears to be hazy, it is the fundus photograph is cleared or not, it is centered on the macula or not, the disc, how is the disc? Then from the disc, you go to veins. In vein, artery and veins are you go to vessels, you describe artery and veins separately. Then you go to the foveal area, parafoveal, and the macular area. You see whether the foveal reflex is seen or not. Is there any anatomical pathology seen or not? And then you note it down and then you describe it in OSCEs. Most of these images will come into your OSCEs. The right side image, the left side image and the right side image, there is a very subtle difference if you would like to see. See these peripapillary area. Here you see the choroidal vessels which are more prominent, and these are all prominently seen in the infrared image also. Here it is not seen. So this is an absolutely normal fundus, and in this area there is a peripapillary thinning. Mostly the pigmentation, the RP pigmentation have reduced. Because of that, you are having more penetration of the infrared rays and you are getting a choroidal reflex out of it. Choroidal vessels reflex out of it. Again, few fundus photographs. Here you see some blood spots, which are more of a blot hemorrhages and splinter hemorrhages. Here you see splinter hemorrhages, blot hemorrhages, cotton wool spots. So it means there is some kind of vein occlusion out of here. Again, this image, there are two things. Here you will see the disc, vessels, the pattern of the branching pattern, everything appears to be normal. But look over here, foveal area. There appears to be a alteration of the foveal reflex. There appears to be a membrane, white reflex membrane, which will be suggestive of an epiretinal membrane. So you will have to say in that way that it appears to be an epiretinal membrane, which will in infrared images, if you see these capillaries, they are more of a straightened out, or some capillaries are hidden. It means that membrane is a little thick membrane, because of which the penetration of the rays is not happening, and it is a fibrous tissue which is lying on the surface. Here it is more penetration. Again, because of that, you are able to see these choroidal veins, choroidal vessels along with the retinal vessels. So it means there is diffuse thinning or diffuse depigmentation out of it. Now I'm moving to the last part of the presentation, which is the correlation between the infrared image, the autofluorescence image with the fundus photograph and the OCT. Why we need all these? Because obviously it is an evaluation per se. It is a step-by-step evaluation which we are doing. We are looking into the macular OCT. We are looking into the infrared image. We are looking into the fundus photograph, which is maybe a pseudo color or it may be a true color image, and also autofluorescence. Those all brought together, we can do a much better evaluation, and then we can have further analysis in the form of angiography, fundus fluorescence angiography or endocyanine angiography. To brush up, again, as I said, generally the infrared image, generally you have a lighten up optic disc. Here you can see the whole of the optic disc is black. It is like a black image. And here autofluorescence. Okay, just one point about autofluorescence. What is autofluorescence? Remember, autofluorescence is a simple term when you are doing an imaging with the fundus fluorescent angiography machine, but you are taking the fundus photos without injecting the dye. So you will send a blue excitation filter. You will get the image, the green excitation. You will excite the fundus with the blue rays, and you will get the green rays out of it again back. Those will be, the blue rays will be filtered out and the green rays will be captured by the camera, and you will get an autofluorescence image. In autofluorescence, the main chemical is the lipofuscin chemical, which gets deposited in with age in the RPE layers. So when you get an hyper autofluorescence or a high autofluorescence, it means there are a lot of lipofuscin deposits in the RPE. If you are getting black color images, it means that area RPE is almost dead and or it is gone because there are no lipofuscin depositions. And there is one important parameter that the blue rays are blocked by xanthophylls and the xanthophylл pigments, which are found in abundance at the exit center fovea area. So when you see a normal image, you may see a black color shadow in the autofluorescence image in the exact center foveolar area. That does not mean that the RP is dead. It is appearing because the xanthophyll pigment has absorbed the blue excitation rays so much that it is not allowing anything to get back to the camera. But the surrounding RPE, you will be able to see a whitish autofluorescence image is like something of this sort. It means the RP is all normal. The only thing is central foveolar area has lot of xanthophyll pigments. Because of that, it is blocked. In this per se image, overall, if you can see, this is all thinned out. I'll just move on to the second.
Dr. Bhandari, we're running out of time.
Yes, ma'am. Yes, ma'am. I'll just wind up all this. This last image, you can see over here. This is the autofluorescence image. This is the black color disc. This, as I said, this is the foveolary area, which is black, but this does not mean the RP is gone. This is the OCT image, RP, IS, everything is normal. This is a CSR image. As you see, you can see a you can see a circular area over here, and the same thing, RP is still working because of that, because of this autofluorescence images over here. This thing again, these all black shadows are RPs all dead. This white hyper-reflective areas is a ongoing dead RP. I mean, it will die off. It is a pathological RPE. Again, this all the black images all dead. So that would be all. I think this is the major images, and thank you everyone. I think I was able to describe some things clearly.
Thank you so much, Dr. Sahil Bhandari, for that very comprehensive talk where you highlighted the pearls and pitfalls of mainly the OCT scan, and seeing that how important the OCT has become as a part of our clinical decision making. It's very important that the images are not only interpreted correctly, but also acquired correctly. So we'll just go a bit deeper into this, and I'll invite a few quick comments from our panelists. So, Dr. Gopal Pillai, would you like to go first?
It is a complete presentation. I think there's nothing more to add. I think it would have been a feast for the postgraduates.
Truly.
Thank you.
Thank you. Dr. Rakesh Purwal, sir, how important do you think it is for an anterior segment surgeon to get a preoperative OCT scan done, and do you routinely get a scan done in all your cataract patients?
Well, ma'am, I'm working as professor and HOD at JLN Medical College, Ajmer. And to my surprise, I have been using OCT at my home also from last 50 years. And I find OCT to be an instrument which is needed by every ophthalmologist for a comprehensive diagnosis of a patient. Mind you, I would always tell my resident and myself that OCT alone is not only going to diagnose. Your indirect ophthalmoscopy plus your 90D fundus examination is very must before doing an OCT examination. Most of the time we are doing OCT first and then thinking about all this. Never do like this. Do always 90D as well as direct or indirect ophthalmoscopy first, and then correlate with your OCT finding. The second thing, I would like to thank Dr. Sahil Bhandari for one important thing, that he's only one of the person who is doing a charitable work in a very remote area. And I have never listened any person, a vitreoretinal surgeon, who is doing a charitable work also, as well as he's doing in a remote area. Hats off to a person who is very close by to me at Jodhpur, which is very close to Ajmer. I have some few questions to Sahil before I, ma'am, just pardon me to give me 1 minute more. What are the parameters, are there any quantitative parameters for Indian population right now? Because we are seeing most of the machine, they are from outside. So are there any quantitative parameters which have been made for Indian population or not?
So I'm not very particularly sure about it, but nowadays the machines are evaluating into it. I mean, like they have incorporated Indian data, but it is not purely just an Indian data. It is a mix and match of both their own particular, like whatever the machine, whichever make, whichever company, they have their own normative data. Along with that, they have a very good scale of the Indian population. It is most of the images which we are nowadays evaluating, we do have it is actually based on we can say really we can rely that it is comparing Indian eyes, because extensively the imaging techniques have evaluated on the Indian eyes, and they have lot of data, but obviously not every machine updates that thing. But now at this point of time, whatever the machines are coming up with do have a Indian base of normative data. So whenever we are comparing it, we can reliably say that yes, it has compared with our Indian eyes. And it shows in the result point of view also. Whenever we are evaluating anything in the or prognosticating it, or we are following up any images, we really see that it is actually matching with your Indian eyes, and it is really giving results which are reliably in comparison with the Indian eyes. So they do have normative data which is incorporated from Indian eyes. Especially, I think most of the data has been derived from South Indian population also, because there's a lot of researchers which is going on down south.
Thank you, Dr. Bhandari. So I think in the interest of time, with that, we'll move on to our third talk for this evening. So I'll just share my screen. So our third speaker is Dr. Abhishek Desai, who's a consultant at the Shri Ganpati Nethralaya Jalna in Maharashtra. He completed his MBBS from the Government Medical College Aurangabad, his MS from the Regional Institute of Ophthalmology at Rohtak. He went on to do a long-term fellowship in Vitreoretina at Shri Ganpati Nethralaya at Jalna, Maharashtra. He also did a fellowship through ICO in surgical retina from the New York Eye and Ear Infirmary, New York in 2018. He's a member of the Royal College of Surgeons and Physicians of Edinburgh and also a fellow of the Royal College of Surgeons and Physicians of Glasgow. Currently, he's working as a vitreoretina consultant for the past 10 years, and he has a special interest in ocular trauma, especially posterior segment trauma and uvea. A keen academician, he also has a number of national and international publications to his credit. He's been a speaker at various conferences, and he has an abiding interest in teaching young minds at various platforms. So to that effect, today he'll be talking to our postgraduates on the Ultrasound B-scan, a ready reckoner for the postgraduates. So over to you, Dr. Abhishek Desai. I'm sure this is going to be another very useful talk for the postgraduates.
Thank you. Thank you. Am I audible?
Yes, yes, you are.
Yes. Now, meanwhile, I'm sharing my screen. Thank you, Dr. Bali, for the kind words, and thank you, AIOS, for giving me this opportunity. And are my slides visible?
Yes, they are.
Yeah. So I'll be talking in brief about the understanding the ultrasound B-scan. So this is how under these headings I'll be proceeding during my talk. As we all know, humans can hear the sound waves of frequency between 20 to 20,000 hertz. The sound waves beyond 20,000 hertz are inaudible to us, and those are called the ultrasound waves. So these are the living examples of ultrasound. These two species, the beluga whale and the bats, they uses the ultrasound power for echolocation transporting from one place to another. And before understanding ultrasound, one must not forget that it complements the clinical examination, but it cannot replace it. And before performing ultrasound examination, we should know in brief about the history, some important clinical findings, and we should have some provisional diagnosis in mind. But this is not the case when you get the ultrasound photograph in your table viva in exam. In that scenario, you need to answer directly But in OSCE, they might give you some sort of history along with the ultrasound photograph so that you can have something in mind, and then based on findings, you can reach to the diagnosis. The common indications in which ultrasound is performed is like in opaque media, any kind of opacity like in corneal opacity or the cataract, or if there is a vitreous opacities like vitreous hemorrhage or endophthalmitis in which the ultrasound is performed. Ultrasound is also helpful in clear media situations such as choroidal detachment, whether to know whether it is serous or hemorrhagic, or in cases of posterior scleritis or in mass lesions. It is very important, and in intraocular foreign body cases. The first commercially available ultrasound was developed by the Nathaniel Bronson in 1972 here. So coming to the basic physics of ultrasound, that sound wave has a frequency and which is inversely proportional to the wavelength, and which in turn is in directly proportional to the penetration, tissue penetration. So higher the frequency, the lesser will be penetration but better resolution, which is in case with the ultrasound biomicroscopy UBM, which uses a probe of 50 megahertz probe and gives us excellent resolution of the anterior segment with limited penetration posteriorly. Whereas the routine ultrasound that we use for posterior segment evaluation is having a probe frequency of around 8 to 10 megahertz, which has an intermediate penetration. So this is how the ultrasound console looks like, which has a probe which is connected to a machine which has a display. The probe contains a piezoelectric titanium zirconate crystals which vibrates and emits sound waves of particular wavelength when stimulated by the electrical energy. Then that sound passes inside the eye, gets reflected from its surfaces, comes back to the probe, where again that is sound energy is converted into electrical signal which is transmitted to the receiver, and image is processed and displayed on the screen, which has a two components. First is the A scan or the amplitude scan, which is commonly used for the measurement of the axial length, and the two-dimensional brightness or the B scan, which looks like this in this image. So generally, the B-scan is performed by keeping the probe over the closed eyelid by using a coupling solution to avoid attenuation, sound waves attenuation caused by the air. Also, it can be performed by keeping probe directly on the globe under topical anesthesia, but in that case, it need to be sterilized after each use to prevent cross-infection. Each probe has a marker or pointer which denotes the upper part of the scan, and based on the orientation of this marker, there are three different types of scans that need to be performed by doing the B-scan. So when the marker or the pointer is perpendicular to the limbus, then it is called a longitudinal scan. When it is parallel to the limbus, then it is called transverse. And when it bisects the cornea or the optic nerve, then it is called the axial scan. The longitudinal scan gives us an idea about the anteroposterior extent of the lesion, whereas the transverse scan gives the idea about the lateral extent of the lesion. So one must make use of all these scans to have a 3D orientation in their mind for any particular lesion while examining the B scan. So the normal B scan, we have this equilucent or vitreous cavity which is lined posteriorly by the retina and choroid, which has 100% reflectivity or the spike on the A scan image. Before doing ultrasound examination for any condition or lesion, we should evaluate that particular lesion or structure under these three headings. How does it look like topographically? Means how is the shape, border, size, location, extension? How is the reflectivity on the A scan, and how it behaves on kinetic evaluation? That is to assess the mobility by asking the patient to move their eyes. So when ultrasound wave passes through a medium, on striking a surface, part of it is reflected back. That is called the echo. And based on the types of echoes, we can get a dot-like echoes in cases of vitreous hemorrhage or vitreous pathologies, or membranous echoes in PVDs, RDs, or CDs, or there can be a mass lesions. So let us see one by one few common conditions that we come across in our clinics or in exams. These classical photographs can be kept for your evaluation. The first is the dot-like lesion. In this case, for example, in asteroids, we get the diagnosis on B-scan is quite unique and straightforward, where we get to see a multiple bright echo-like structures in the vitreous cavity, which has a moderate to high reflectivity. And the most distinguishing feature in asteroids is the presence of clear space between the posterior extent of the asteroid and the posterior hyaloid. Whenever there is this clear space is clear-cut indicative of the presence of asteroid hyalosis. Now coming to the next type of dot-like echoes are in cases of vitreous hemorrhage, which usually appear as a multiple dot-like or short lines like echoes within the vitreous cavity with a chain of low spikes on a scan. So we see this multiple dot-like and lines-like echoes with low reflectivity on the A scan suggestive of vitreous hemorrhage. This is one more example where we see this line-like echoes along with multiple dot echoes with low reflectivity on A scan suggestive of the vitreous hemorrhage. Another important diagnostic dilemma in early post-operative period where B-scan is the investigation of choice is the difference between to differentiate between these two conditions. Like one is endophthalmitis and another is the toxic anterior segment syndrome or TAS. So in endophthalmitis, the inflammatory cells they appear as a multiple fine dot-like echoes with moderate reflectivity spread throughout the vitreous cavity, whereas usually it is absolutely clear or equilucent in cases of TAS. So to decide what needs to be done, the B-scan comes handy in such difficult situation. Also, in some lens related abnormalities or to know the lens status of the patient where the cornea is opaque or that view is not there, then B-scan is very helpful where we can see the posteriorly dislocated crystalline lens in this photograph. Also in pseudophakic, it gives a classic appearance of that is called reverberations. What are reverberations? Basically, when sound waves pass through a highly reflecting surface like a lens or IOL, the part of them, sound waves, they keep on reflecting back and forth within the vitreous cavity, giving this appearance of series of shadows called reverberations. Reverberations are also seen in cases of suspected glass intraocular foreign body when sound waves pass through it perpendicularly. So B-scan comes is very essential to know the lens status when the cornea is very clear. Now coming to the membranous lesions, the first one is the posterior vitreous detachment. So topographically, it appears as a smooth line-like structure, open funnel, which may or may not have attachment to the optic disc with variable reflectivity, but not high as that of the retinal reflectivity. That is, for retina, it is 100%. So less than 100% reflectivity can be seen. But the most distinguishing and characteristic feature in cases of PVD is the kinetic movement, or it has an excellent undulating after movements when we ask the patient to move the eyes. For example, in this case, we have this membranous lesion in the vitreous cavity, which is not having any attachment to the optic disc. But when we ask the patient to move the eyes, it shows excellent undulating after movement. So it is suggestive of complete posterior vitreous detachment. Why complete? Because it doesn't have the attachment at the ONH or optic nerve head. Now this is another example where we have this membranous or line lesion in the vitreous cavity, which is showing good movements with variable reflectivity and associated multiple dot-like echoes beneath this membrane. So this is an example of complete posterior vitreous detachment with subhyaloid or pre-retinal vitreous hemorrhage. So many times when patient brings the report of the ultrasound B-scan when done outside, it is confusing by seeing only the photograph. For example, in this photograph, we see it is like a stalk-like structure arising from the posterior part of the globe and coming anteriorly. So one can suspect that it might be a case of closed funnel retinal detachment by seeing only the still photograph. But when we do the kinetic evaluation, we can see the excellent movement or the undulating after movement seen in that membrane, that is making it a clear-cut diagnosis of complete posterior vitreous detachment. So this is the importance that even if patient brings the report from outside, we should do evaluation on our own and just not depend, even if it is done on the same day outside. So moving on to the next more important membranous echoes that can be seen on ultrasound are the retinal detachment. So retinal detachment appears as a smooth membranous structure which will always have attachment of the uh, uh, at the optic nerve as opposed to the posterior vitreous detachment that we have seen earlier, and it will show the 100% spike on a scan. And when we ask the patient to move the eyes, because of the attachment to the optic nerve head, it has some limited movement. It may not be as extensive as that we have seen in this photograph. These movements will be slightly restricted because it has attachment to the optic disc. So this is another example where we can see a stalk-like thing arising from the optic nerve head, which has the highest spike suggestive of the posterior closed funnel retinal detachment with fine multiple dot-like echoes submembrane or subretinal. These can be seen in trauma cases. This might be suggestive of the subretinal hemorrhage, or in long-standing retinal detachment. And these can be seen as a cholesterol debris or crystals can be seen like this multiple fine dot-like echoes subretinally. So the not only the still photograph is important, but the movement is also important. For example, in this case, we see two membranes which are showing the after movements. One is in front, which has an excellent after movement, suggestive of the complete posterior vitreous detachment, along with this open funnel kind of smooth membranous structure, which has attachment of the optic disc, suggestive of retinal detachment. So it is a case of basically a complete PVD along with retinal detachment. Also, B-scan is also helpful to know whether the retinal detachment is long-standing or the acute one, where if we see this multiple intraretinal giant cyst, or if we this stalk-like structure arising from the ONH, suggestive of closed funnel retinal detachment, these features are indicative of the chronicity or the long-standing status of the retinal detachment and helps to plan our surgery and to explain to the patient what would be the prognosis. Also, B-scan is really helpful to distinguish between the different types of the retinal detachment. Like in exudative detachment, we can demonstrate the shifting fluid or the shifting extent of the detachment in sitting and supine position. Whereas in fractional detachment, the extensive adhesions of the vitreous with the retina can be seen. That can lead to the appearance of this tent-like or the tabletop detachment associated with vitreous hemorrhage in PDR cases. So by seeing the B scan where view is not visible because of the vitreous hemorrhage, we can come to know that patient is not only having the isolated vitreous hemorrhage but associated tractional detachment. So that will help to prognosticate the case, to explain the prognosis to the patient and plan our surgical action beforehand. Now moving on to the next membranous lesion that can be uh, diagnosed based on B-scan is the choroidal detachment. So generally it appears as a smooth dome-shaped lesion membrane which is seen in periphery beyond the equator but sometimes can be seen extending up to posterior. On A scan, you will get to see a double peaked or the M-shaped spike because of the retina and choroid on low gain, relatively low gain. And on kinetic evaluation, it will have mild or no movements as opposed to the PVD cases or retinal detachment. So it appears as a smooth dome-shaped structure. If those two domes are touching each other, then it is called a kissing choroidals. And on A scan, you get to see this bi-peaked or M-shaped spike on A scan. So on kinetic, sorry, the video is not playing. On kinetic evaluation, the movements are minimal or none as compared to the previous two membranous lesions. On under the dome, sometimes this straight line can be seen. This is indicative of the, or this is a vortex vein that can be visible under the dome in choroidal detachment cases. B-scan is also helpful to distinguish the type of the choroidal detachment. When we see the echolucent cavity underneath the dome, then that is suggestive of the serous choroidal detachment. But if we see multiple dot-like echos under the dome, then that is suggestive of the hemorrhagic choroidal detachment. If we follow these hemorrhagic CD cases progressively, then we can diagnose the clot lysis, and also we can plan the site of drainage if we are planning surgical drainage based on the B-scan. So B-scan is really helpful in such cases to plan the site of drainage and the timing of the drainage. So again, to summarize, the PVD will have, may or may not have attachment of the disc with variable spike, but the characteristic feature is marked undulating after movement when we ask the patient to move the eyes. Whereas RD will always have attachment at the disc with 100% reflectivity with moderate or mild movements, and CDs are usually located peripherally with dome-shaped cavities with double-peaked spike with very minimal or no movements. Now moving on to the next set of common conditions that might be seen or asked in exam on B-scan is the mass lesion, in which the common ones are the melanoma and retinoblastoma. So B-scan is a must to be done in cases of melanoma, where we can measure the size of the lesion, thickness, exact location. Characteristically, it appear as a collar button or mushroom-shaped lesion located commonly at the posterior pole with low internal reflectivity because of the tight arrangement of the malignant cells within the lesion. And if we join these peaks of low reflectivity on A scan and make this will make an angle with the baseline that is called the angle kappa. Also, it may have acoustic hollowness that indicates the tumor necrosis, and it is very helpful in follow-up period after doing the local therapy to assess how it is how its response to the local brachytherapy or local therapy. So moving on to the another important condition, like a child with leukocoria, B-scan is really life-saving because it has a typical presentation, or retinoblastoma can be diagnosed easily on based on doing the ultrasound, where we can see this calcification within the globe or within the lesion, which has a moderate to high reflectivity suggestive of retinoblastoma. And also it is helpful in follow-up period to know whether it is regressing or again at new site it is appearing, or in other eye also it is appearing or not. Now moving on to the certain miscellaneous conditions that we come across commonly, the one of the important ones is the T sign. What is T sign? It is usually seen in cases of posterior scleritis or panophthalmitis, where we see the thickening of the retinochoroidal layer along with the zone of echolucency beneath it because of the collection of fluid in the subtenon space. So when it involves the posterior pole, the optic nerve gives appearance of the vertical arm of the T, and this peripapillary area, you get this horizontal arm of the T. So T sign is really important in cases of posterior scleritis cases or the panophthalmitis cases. Another important condition in which B-scan is helpful is to diagnose and to locate the intraocular foreign body cases in trauma cases, where the IOFB usually appears as a bright echo spot located within the vitreous cavity with the trail of shadow or after shadow suggestive of comet tail artifact. But one should be careful while performing B-scan in open globe injuries. Generally it should be avoided in open globe injuries because it requires a contact of the ultrasound probe to the eyeball, causing a risk of increasing the pressure and extrusion of the intraocular content through the wound. So generally it should be avoided in open globe injuries. But for diagnosing the how many IOPs are there and where it is located, it is very helpful to plan surgery before moving on to the surgery. Now, another set of confusing diagnosis is whether it is a staphyloma or coloboma. That is a common question that can be asked in exam, that based on B-scan, how would you differentiate between the two? So in staphyloma, usually it is seen in cases of pathological myopia where we get the long axial length or the long globe with backward bowing of the globe, like a pear shape. It can be seen with thinning of retinochoroidal layer at the posterior pole. Whereas in coloboma, there is a sharp excavation. It's seen with or without involvement of the optic nerve head at the posterior pole. Usually, it is located in the inferonasal quadrant. So this way, these two conditions can be distinguished between the two. Now, moving on to the another common condition is the silicone oil filled eyes. How does it look like? So many times the cornea is hazy. Patient gives a brief history that he underwent some surgery. Details are not available, and you see B-scan image like this. So basically, in silicone oil filled eyes, you get a pseudo elongation of the globe because the speed of the sound waves in vitreous cavity is around 1530 meters per second, whereas silicone oil is a relatively denser medium as compared to the vitreous, which has a lower speed, that is around 980 meters per second. So because of the less sound speed in the silicone oil, you get a pseudo elongation of the globe. Also, the findings of retina attachment or detachments are not really helpful or reliable in silicone oil filled eyes. Only you get to know whether the eye is filled with silicone or not. Rest of the findings are not really helpful in silicone oil filled cases. Now, moving on to the last condition that commonly diagnosed based on B-scan, whether it is a case of true papilledema or pseudo papilledema. When in doubt, you have a slightest doubt of the optic disc Drusen, then B-scan is helpful to confirm your diagnosis, because the Drusen optic disc Drusen basically it contains a calcific material which appears as a bright spot over the optic nerve head, which persist even on the low gain or reduction of the gain on the ultrasound B scan. So making it simple and not to frighten the patient, because in papilledema we need to explain them that you need to do urgent CT scan or MRI to rule out any raised intraocular pressure. But if it is a pseudopapilledema, because of the optic disc Drusen, you get relieved, and even the patient also will not get frightened because of your diagnosis. So, to summarize, basically, B-scan, the postgraduate should not know only from the exam point of view, but it should be known from their clinical perspective, because it is a very helpful tool and it is easy to master by only doing some practice. It is not very difficult, and it is a non-invasive, reproducible, so it gives a very important clue, especially when the media is not clear, and sometimes in certain conditions, like in endophthalmitis, post-operative endophthalmitis, or TAS, or true papilledema, pseudopapilledema, or whether it is RD is there or not. So that way, B-scan should be understood, and it is not really difficult to know it. Thank you. Thank you so much.
Thank you, Dr. Abhishek Desai, for that wonderful talk. You brought out the intricacies of a B-scan so well, and you also gave excellent pointers on how to interpret a B-scan. And I must compliment you on the way you illustrated every point with those wonderful videos. So thank you so much. You also very well highlighted that B-scan is a dynamic examination, and we should not try to interpret it just by seeing a single static photograph. So that was a very important point that you brought out. So with
Thank
that, I take the discussion forward to our panelists. Dr. Gopal, would you like to add something to that? Or
Again, it
any
is a
comments?
comprehensive talk, so I would like to say that in an acute situation, like for example, a corneal perforation, scleral perforation, an ultrasound, actually the resolution of an ultrasound is like, a B scan is about 400 microns when we are using 8 to 10 megahertz, as compared to a 1 mm CT scan, which is about 1 mm. So I think smaller foreign bodies that you can lodge in the eye can easily be picked out in a CT scan. Then again, in the acute situation, a soft approach without a complete formal thing will give you a lot of information regarding, primarily if there's a traumatic end off or, foreign body, the presence of, the lens, you'd not be knowing about the status of the lens. So that is one thing in an acute situation. For that, probably, even if, like, for example, a lot of hospitals, see, if the eye hospital is there, there will be an ultrasound room, and maybe that room is not open in the night. And in a multi-specialty hospital, generally, we can also use the ultrasound machine, the general ultrasound machine, to gather reasonable information. One thing that we are not usually using in an ultrasound is the Doppler part of it, which can very well look at the central retinal artery, which can very well look at the ophthalmic artery blood flow, the resistivity index, and give you a lot of prognostic information regarding diabetic retinopathy, retinal vein occlusions, etc. So that's another point that we have to look at. Then I think you have covered everything comprehensively. Congratulations, doctor.
Thank you. Thank you, sir.
Dr. Rakesh Purwal, sir, any comments?
Thank you, Abhishek. A wonderful presentation. Only one thing I would like to add, the role of color Doppler with ultrasonography for knowing in patients of normal tension glaucoma. Is there anything new, upcoming news about it?
Sir, I'm not aware about it. Maybe I'll look into it and I'll let you know.
Okay. Thank you. Thank you.
Sir, one question. When we have this suprachoroidal hemorrhage of this thing, like clot lysis, as you said, how do you actually identify on B-scan clot lysis? I mean, like, what are the
Basically, when we do the immediately next day, if any patient faces the suprachoroidal hemorrhage kind of situation on table, we close that case. And next day, if we do B scan, we see a multiple large kind of lesions over the dome, under the dome. And if we follow those patients in close monitoring every alternate day, if we keep on doing the B scan, then we see the disintegration or the that big lesions or big echo dots are getting converted into a finer little dots. Then that we come to know. Generally, it takes around 8 to 10 days or around 8 to 12 days time. So if we follow that closely, then we will feel the difference, because we need to do the on the same area every day or every alternate day. Then we will come to know that it is getting disintegrated, and that is the time when we can plan the our sclerotomy, drainage sclerotomy, to drain the suprachoroidal hemorrhage.
Then how much disintegration? I mean, is that dependent on the number of days, sir, generally, or on B scan you can see some signs of that? Okay, this has disintegrated sufficiently enough to drain. Like maybe 5 days later also, can it be seen very well seen on B scan, or we generally have to wait for the days like 7 to 10 days, then only we drain it? So that disintegration, how do we decide, sir? How many days?
Generally, it's a combination of two, the days as well as the B scan findings. So even if B-scan means I would prefer to wait for at least 10-12 days. Maybe Gopal sir would like to add his experience, or Tinku madam would like to add her experience. Generally, we should wait for at least 10-12 days, and then on kinetic evaluation, you see that those dots are moving when we ask the patient to move his eyes, then that is the time then you decide to drain it.
Yeah, so generally not before 10 days. I would not go in
Yeah.
for a drainage before 10 days. And then, of course, the ultrasound would add to that. If you feel that it is not sufficiently large, then you could wait a bit longer.
I would like to just add, Sahil, that, intraoperatively, if you have a suprachoroidal hemorrhage, generally as younger retinal surgeons who think that we can do everything, we would also try to drain the hemorrhage right then and there, which would rather be a mistake. So especially if you are doing a retinal detachment and if you have a suprachoroidal hemorrhage right in front of you, it is always better to stop operating there and give the patient position so that it moves away from the fovea. Because, the more and more the suprachoroidal hemorrhage in such a case can become subretinal, and the subretinal hemorrhage, since the patient is lying supine, will come directly right under the fovea, and the final prognosis will be worse than if you close the case immediately, give the patient position, and then manage. Classically, we have been using about 8 to 10 days, or maybe like Abhishek sir had said, we would use about 10 to 12 days because it is suprachoroidal and not subretinal. Really no harm done in waiting for that extra week to liquefy it. But currently there are some studies, and I have also tried suprachoroidal TPA to lyse the clot faster so that you can move in faster. But so because this eye is usually a little inflamed, to get the suprachoroidal injection into the correct plane requires a bit of expertise. That is the flip side of it, because we are not used to suprachoroidal injections as much as we are used to intravitreal injections. Probably that's a learning curve, which probably we can learn in the times to come. Thank you.
Thank you,
Thank
sir.
you, Dr. Pillai. Yeah, anyone else who would like to add something?
I would just like to thank Tinkuji, not only to you, but to the whole AOS
Thank you,
on
sir.
just such a good national movement for all the medical colleges, including the resident, even the faculty like we, to have such classes regularly. It will be a big milestone for all of us to learn a lot and have a good interaction. Thank you to Dr. Samar Basak and Dr. Honavar for such a wonderful movement. Thank you, ma'am.
Thank you, sir. Thank you for your appreciation. So before we end, just a quick tip for the PGs that, when they're starting to do a B-scan, it's always a good idea to take patients with a clear media so that you can orient, you can actually see where the retinal detachment is, where your macula is, you can corroborate it after seeing the fundus of the patient. So in the initial part, you can take up such patients so that you know whether your three-dimensional thinking is correct or not. So with that, we come to the end of this episode of GuruSangam. I would like to thank all our speakers for their excellent talks, superlative talks actually, and to the discussants for their very astute comments. Thank you all for sparing time on this Sunday evening to be with us. And it's been a very gratifying experience. I'm sure it's been a great learning, not only for the presenters, the viewers, and all the participants. So I also request the PGs to log in again. This is a series of an ongoing program, and we'll have more episodes on next Saturday evening and then Sunday morning and Sunday evening. So do watch out for the information on your mailbox. And with that, I bid you all a very good night. Thank you so much once again. Thank you.
Thank you. Thank you.
Thank you, everyone. Thank you.
Good night.
Thank you very much.